We are drawing to the edge of our conference, and I am pleased to invite Dr. Shorok Hassan to join us next. Speaking of the Wu-Tang Clan and speaking of Staten Island, Dr. Hassan did her medical school training in New York City. She then completed her residency training at SIUH on Staten Island, where she was a chief resident and became an attending physician, where she currently is the clerkship director. Along with creating innovative and novel approaches to medical education, Dr. Hassan is in search of the finest steakhouse. Now, I know that this can be a particularly hot topic of debate. I know I have a very hard opinion on this, but if anybody has some comments or suggestions, I'm sure she'll be willing to take them in the comments. Thank you so much. Dr. Hassan, take it away.
Thanks, Sally. Yes, definitely let me know of any steakhouses. Thank you so much for having me here today. And thank you for that lovely introduction. And thank you for the Wu-Tang intro, because that is a great leeway being from Staten Island, and definitely protect your neck. But I'm Shorok, I'm from Staten Island University Hospital. And before we begin, I just want all of you to take a look at this picture. So she's holding this laryngoscope blade, confident and poised. No, this isn't me. I typically don't hold a blade in my hand and have someone take a picture of me in a subway station or an alleyway. But this is how I'd like to envision all of you by the end of this lecture, as confident and poised as she is, because we're going to be talking about a particularly sick patient. We're going to be talking about intubating a GI bleeder. So what I want you to do for the next few seconds, these minutes, is envision yourself in each scenario and ask what it is you would do. What wouldn't you do? How would you manage this patient? Imagine yourself in the critical care area of your emergency department, working with that attending that you know as a black cloud. And there's just mayhem. You're taking care of all these sick patients you never thought you'd be seeing. So many things are happening at the same time. And if you work at Staten Island University Hospital, you'll know at some point that you're going to be taking care of someone from the mafia, particularly this patient. So for those of you who don't know who this is Gregory Scarpa. He was part of the mafia. True story, he had stomach pain, so he started taking aspirin thinking that aspirin would help his pain. He then ended up taking a bottle and suffered a major GI bleed. He's your patient today. He's pale, he's hypotensive, and he's extremely tachycardic. What I'd expect you to feel at this point is your heart is going to be beating very fast as this ends up happening in the next few seconds. There's blood vomiting everywhere, basins and buckets of blood around the bedside. So again, heart beating out of your chest, you're feeling palpitations, you're not sure what to do next. Because not only are you taking care of someone that's known as the Mad Reaper, but you have to know how to intubate this patient quickly within the next few minutes. You're not going to feel like this today. You're going to feel like that picture depicted, confident and poised. So take a deep breath. And remember, as with anything and with all these lectures, the one thing they've been teaching is that preparation is key. That's why you're all here today, to learn and gain insight on how to prepare for these critical situations, these scary situations. All right, so what's the first thing? You guys have all mastered this, so place your PPE on, and next get medications on board early. So many things are going to be happening at the same time, but the reason why I want you guys to remember these two medications and starting them early is because they take time to work. They're both prokinetics, so they're going to help empty the stomach. It's going to be Reglan 10 milligrams IV and erythromycin 250 milligrams IV. In addition to helping to empty the stomach, the Reglan is going to act as an antiemetic, and it's going to increase that lower esophageal sphincter tone, which means less regurgitation of that blood. So remember, takes time to work, start them early. You also want to remember to resuscitate before you intubate. This is not the focus of this lecture. This is a lecture in itself, but I just want to spend a few seconds on this. This patient is going to be hemodynamically unstable. They're going to have a massive GI bleed. So more than fluids, you want to make sure you follow your massive transfusion protocol, get blood on board early. In addition, you want to make sure to have the pressors on the pump ready to go for after you intubate, including those push-dose pressors, which now you know how to make from that beautiful video earlier, because this patient is going to get hypotensive after you intubate. They're already hypotensive. So remember, preparation is key. The next important thing is the NG tube. Now, this is controversial. You want to limit regurgitation and aspiration, so some may avoid this, but I typically try to place the NG tube if I think it's possible. It makes sense, right? You're going to place this NG tube, it's going to continuously empty the stomach while it's on suction. It's going to remove that blood and allow you to have a better view. So try to place it if possible, and remember, it's not contraindicated in the esophageal varices. The other important thing is your positioning of your patient in your intubation, which was mentioned earlier in these lectures, specifically the bed up, head elevated position. So this is based on anesthesia literature. And what you want to do is have the external auditory meatus in line with your sternal notch. This is going to do a few things for you. One, you're going to have less dependent alveoli, which means you're going to have better pre-oxygenation. Two, you're going to have a longer apnea time, which means your O2 sats are going to be higher for a longer period of time. The other benefit of this is that if your patient has a lot of adipose tissue, this is going to offload that mass and allow you to get a better view of your glottis. So get that patient in the bed up, head elevated position at 30 degrees. If they start vomiting, put them in Trendelenburg to get the emesis out of the lungs. Hopefully by this point, your medications are kicking in and you could place your patient ready for intubation. All right, so you've got your prokinetics on board, you're resuscitating before you're intubating, you even placed an NG tube on suction, and you're positioning your patient. But what's in the money bag? What do you need for this intubation to make it successful? Well, we're going to talk about pre-oxygenation more, but remember to have high flow nasal cannula or your nasal cannula on blast, and if you can, a non-rebreather, so you pre-oxygenate well. The patient might be vomiting, so you may not want to put the non-rebreather yet, but if you can, put it on the patient. The other important thing is your bougie and your LMA, which we'll get to, and then your induction agents. Recall, this is a hemodynamically unstable patient, so they're hypotensive. The two sedative medications that I would pick are etomidate or ketamine, but at half the dose. So for etomidate, I would use that half a dose of 0.3 milligrams per kg. The ketamine, I would use 0.5 milligrams per kg. You want to remember this patient could get hypotensive even after you intubate, and they're already hemodynamically unstable. In terms of your paralytic, I would go for rocuronium and use it at a higher dose of about 1.5 milligrams per kg. The reason for this is rocuronium is going to act like Reglan in the sense that it's also going to increase the lower esophageal sphincter tone, preventing further regurgitation. So why not? So you're getting your induction agents, cardiac stable agents on board to help you intubate. At this point, you're also going to get your intubation material for this patient, which was spoken about in depth earlier by many people, but specifically having the video laryngoscope on hand. I would go for this immediately because you want to see what's going on and have everyone around you that's going to be helping you see what's going on as well. You always want to prepare for anything that may go wrong, so have direct as well, but make sure to have video beside you and make sure it's working. The other thing is your respiratory therapist will get the BVM at the bedside. This is the one time I want you to not use the BVM. This is because when you try to bag the patient before you intubate, it's going to cause gastric insufflation, which is going to induce vomiting in this patient by distending the stomach. So if you do have to use it for any reason, you're going to do it gently and slowly at 6 to 10 breaths per minute, if at all. But remember, this is why that pre-oxygenation is so important. This is why I want you to do the bed up, head elevated position at 30 degrees to avoid this at all. All right, now you're ready to intubate the patient. Make sure you have suction catheters at the bedside because these next 3 steps are going to have to involve this because the patient's vomiting blood. Imagine yourself in each scenario and then ask yourself which one you'd use. The first one is pretty straightforward. You have 2 suction catheters set up at the bedside, and you're going to need 2 assistants for this. Self-explanatory in the sense that you'd be using your video laryngoscope. Remember, you want them to see what you're seeing. Your 2 assistants are each going to have a suction catheter in their hand. They're going to come from the corners of the mouth while you're trying to intubate, continuously suctioning all that blood so that you get a good view and hopefully have a view of your airway to intubate. What happens if you don't have 2 assistants? Because remember, this is a hectic day. You're with that cloud, big black cloud attending, and everything is mayhem. Or you don't have 2 suction catheters at the bedside ready to go. Even more so, what happens if the airway is so small that you feel like you can't fit 2 suction catheters and your video, and it just seems like this isn't working? This is when I would consider doing the salad approach. not the salad, obviously, but suction-assisted laryngoscopy airway decontamination, which was coined by Jim DeCanto and his colleagues. I'm going to play a video, but before we do this, again, envision yourself in this scenario. I'm going to take you step by step and picture what you would be doing. So you have your video laryngoscope in one hand, your suction catheter. Remember, this is your DeCanto suction catheter, so that rigid large bore suction catheter in your right. As you're looking at the airway and seeing all this blood, you're coming in from the right side with your suction catheter. You're suctioning the hypopharynx, you're going into the proximal esophagus, you're removing all that blood, and you start to get a good view of your trachea, your vocal cords. You then are going to move from the right side and pin the suction catheter to the left with your blade, securing it in place so that it continuously suctions all the blood, allowing you to get a good view of your airway so that you could intubate. All right, let's play this video. Coming in from the right side, suctioning, getting a better view. So now seeing your airway, vocal cords, hopefully. Gonna move to the left side, pin it with your blade in place, pass your bougie, and then you can successfully intubate your patient. Simple enough, right? But what happens again? You feel like the airway is just too small and you're not fitting that suction catheter well, or you can't pin it, or there's just so much emesis, so much blood obscuring your view, and you don't think this is going to work for you. This is when I'd say use the take the shot approach. So again, let's go through this and then we'll play the video. Same idea, you're using your video, you're coming in from the right side, you're suctioning, but now you get a good view of your vocal cords, your trachea. Instead of going to the left side with that suction catheter, you're actually going to place that large bore suction catheter in the trachea at the proximal portion, remove the top of the suction catheter, pass your bougie through it like a Salinger technique, which is exactly what this is. Then remove the suction catheter, bougie in place, your airway secured. You could either leave the suction catheter aside if you think it could fit, pin it to the left side to allow continuous suctioning, and successfully intubate your patient. All right, let's take a look at this. Coming in from the right side, your suction, get a good view of your airway, remove the top portion of that suction catheter, grab your bougie, Salinger technique, pass it through the suction catheter. You're now going to remove that suction catheter. In this case, he actually reattaches it, pins it to the left side, like you did with the salad approach, allowing continuous suctioning of your proximal esophagus, grabbing your ET tube, placing it over your bougie, and successfully intubating. Easy enough, right? You have 3 different ways to successfully intubate this patient, 3 ways that I know you could master. But what happens if you do one approach and you find it's not working for you and you have to change to a different approach and the patient starts desatting? Now you want to use your BVM. You need to get the O2 sats up. This is when I'd say grab your LMA because it's going to reduce your gastric insufflation, reduce distension of the stomach as it sits on the glottis, and bag gently and slowly. In addition, as mentioned by Ruben earlier, you could use those fancy LMAs that actually allow you to intubate through the LMA. So the iGel or the fast track LMAs, if your facility has it. Your facility may not have it, but if you do, you could place it at this point and intubate through the LMA, use your fiber optics, or even the flexible endoscopy and go to that if you have that. That might be the new approach to doing things with these GI bleeders. The last thing I want to mention is you could add a meconium aspirator actually to your ET tube and suction as you intubate, which allows you to have another form of suctioning in addition to the other suctioning that's taking place. This may soil your ET tube, but you could always replace it later. All right, so we went over a couple of things, but I just want to recap really quickly. Get prokinetics on board early, they may help, so why not give it to them? You also want to remember to resuscitate before you intubate. Give blood, give your pressors on board after you intubate. NG tube, as well as the bed up head elevated position for proper pre-oxygenation, as well as your medication induction agent. So your sedative at a lower dose, your rocuronium at a higher dose that increases your lower esophageal sphincter tone. You also want to remember to try to avoid using the BVM if at all. Again, bed up, head elevated position to help you pre-oxygenate well as making sure to use video with your suction catheter set up to use one of those 3 approaches, either the 2 assistant suction catheter approach, the salad approach, or basically the Salinger technique, the take the shot approach, having your bougie and your LMA on board as well as backup. You would have successfully intubated your first mafia patient at Staten Island and your GI bleeder, leaving it completely spotless. and being that boss I know all of you could be as we started in the beginning. Thank you.
Dr. Hassan, thank you so much. That was fantastic. Really great tips. I love the idea of using the Seldinger technique through the bougie through the suction catheter. That's great. I'm going to definitely practice with that. I have one question for you from the chat, which says from Stacy Frisch. She asks, how do you use the suction connected to your ET tube with a stylet, or do you just forego the stylet when you're going to try and do that?
So there's actually a whole big discussion on this. Typically you're not gonna have the stylet with this if you attach a meconium aspirator to the ET tube to intubate. However, some people have devised these little tricks to try to do this. I could actually send the link to you if you'd like in the chat, but typically you're gonna eliminate using the stylet for the most part if you do attach a meconium aspirator to the ET tube, which makes it a little difficult, which is why this would not be my first approach.
Excellent. Probably one of the reasons maybe that our anesthesiology colleagues make us practice intubating without a stylet every now and then in the operating room. Right?
Exactly.
Thank you very much, Dr. Hassan.